Hello and welcome to another edition of our InnovAiT podcast. My name is Dr. Sadia Ayaz. I work as a GP in Southwest London, and I have the pleasure of having with me on today's podcast Diane Bayliss. Diane is a clinical risk educator at MPS Medical Protection Society. She's also a registered nurse by profession, and she's been working with the Medical Protection Society for over 10 years. Wonderful to have you with us today, Diane. Good morning.
Good morning. Thank you for inviting me, Sadia.
Thank you. We're going to be covering lots of various important topics this morning, but essentially looking at issues around complaints, something that most of us as trainees, as GPs, wherever we are in our profession, we do have to encounter. Complaints don't always have to be negative. There's a lot of positive that we can take from them. There are often a lot of learning that we get out of complaints, and it's looking at them from the perspective of those that deal with them day in, day out. What we should be doing when we receive complaints, the most important factors that determine complaints, and how we go about managing them. So we have a little bit to cover, and I'm sure all going to be very useful and interesting for our listeners. So without further ado, Dan, my first question to you in regards to this topic would be talking about COVID and how difficult this year has been for all of us in the healthcare profession. Sadly, we also have had to deal with lots of complaints because of different ways of working, because of restrictions to patients getting access to facilities, medical care when they have needed because of the pandemic. Over the last year, in your view, what would you say are the most common areas of complaints that GPs have had to face as a result of the pandemic? What's your experience been like having to deal with it as an MPS?
Yes. So many complaints during the pandemic have centred around communication, and this is not a new theme. However, over the last year, complaints have been specifically related to patients' understanding of the new ways of working at the practice and across at the NHS as a whole. We know that general practice had to make a huge pivot almost overnight in how they provide services to their patients. And although the majority of patients understood this, some of them did not. So, for example, the misperception that GPs were closed or not doing any face-to-face consultations or home visits. And we've seen some comments from complainants who made comments that they think doctors are using COVID-19 as an excuse for saving money or reducing or even closing services. And again, some of these comments have been made in particular where home visits or face-to-face appointments have not been offered. But without a doubt, this is a lack of patient understanding around the restrictions in the appointment system during COVID. So we know, for example, that most practices have been operating a system whereby all patients who contact the practice are assessed by a clinician by telephone. However, again, that perhaps was not communicated to the patient, and we've had assisted our members with complaints dealing when the patient hadn't been told that it was a telephone conversation and had attended the surgery and then made a complaint. So the decision making around the criteria for a face-to-face appointment is also not well understood, especially where the patient thinks that they should have a face-to-face appointment or an examination, and it's not been clearly explained to them why they are having a telephone consultation instead. And also, another source of complaints had been around some IT or other technical issues that come with the increased use of telemedicine, such as issues around poor signal or connectivity. So, for example, there was one case where a family member had been acting as an interpreter for a relative during a telephone consultation, and they had complained afterwards about the manner and attitude of the GP because they said they felt they weren't being listened to, and they claimed that the GP had hung up on her, whereas in fact the GP was using a mobile phone. The signal was poor and it kept dropping out, and he said that he told them that he was going to hang up and ring back on the landline. So clearly there was, the family misinterpreted the situation. So issues around that really. And also, medical protection is aware that GPs have been concerned about the possibility of complaints being made by patients as a result of delayed or misdiagnosis made on the basis of remote consultations as well.
Talking about remote consulting, obviously it's been challenging times getting used to familiarising ourselves with very different technology. And you mentioned some of that already and the complaints as a result of that. How best would you say doctors are able to protect themselves from complaints when they're consulting remotely? There are a lot of challenges when you're consulting via telephone, obviously not seeing the patient face to face. It's harder to gauge what the issues might be, what the concerns might be, and there's always that worry of missing something. So what would you say how one can actually handle these anxieties and make sure that we are practicing safely?
So communications, the theme again here. So we know that good communication skills are a cornerstone of effective and safe clinical care. And indeed, the research tells us that patients often use the interpersonal skills of the healthcare professionals as a proxy when evaluating whether the care they receive is good or not. And poor communication makes it more likely that the patient will seek information in different ways, such as complaining or taking legal action. And when you put communicating remotely via the telephone or on video into the mix, sometimes on the telephone where you lack these visual clues, this causes more challenges for the clinician. Really, telemedicine involves a whole new set of skills. And here at Medical Protection, we have developed a series of webinars specifically on this subject, and we have various resources available on our e-learning platform to support our members. But there are some ways, a few key tips and ways to minimize these risks to ensure that the best possible outcome for your patient when it comes to telephone consultations. So things like asking more questions. You should consider asking more questions than you may do in a face-to-face consultant with the patient. So in order to ascertain the facts and make sure that the patient clearly understands what is being discussed. Make sure that you can see and hear each other clearly, whether it's on the telephone or on the video, and let the patient know that this will feel different than sitting with you in an examination room. Think about how you connect and convey empathy. So we know that patients experience empathy when doctors listen carefully and summarize both the content and emotions of the story. And in a remote consultation, this can be done through the use of short empathic comments such as, "That sounds tough. I'm sorry to hear that," and saying yes as you nod. You might be familiar with the phrase bedside manner. So now we need a webside manner. So think about your webside manner. That's how you connect with the patient. So if you're using a video, try and position yourself at eye level with the camera and focus on the camera when listening and talking, and try to allow as much non-verbal communication as possible. So letting the camera see your head and neck and shoulders and encouraging the patient to do the same. Also, slow the rate of your speech and be as clear as possible when you are trying to establish this eye contact on the video. Also, consider the use of a chaperone. So if you are undertaking an examination via a video consultation, and if you decide that a chaperone is required, they could be present with the doctor virtually or in the same room and witness the nature and extent of the video examination that was undertaken. Check the location of the patient. So it's important to check where the patient is based at the time of the consultation. They may not be at the address that you think they are, and this could be vital if they are acutely unwell and need urgent medical attention. You may also wish to explain to the patient the importance of ensuring that they are somewhere private where details of the consultation cannot be overheard or seen by someone else. Clarify the reason why this is a remote consultation instead of face-to-face. As I said earlier, some of the complaints that we've been helping our members with is around this subject. So it's really important to ensure that the patient understands the need for a remote consultation and agrees to this, and also ensuring that you document their consent. So after you've had your discussion with the patient, concluding the conversation and agreeing further actions. So always give clear safety netting advice. So be specific, explaining the signs of something getting worse or what to do in that event. Tell them what you would expect to happen if all goes well or when you would be worried. So, for example, if you're unable to keep down fluids and what to do in that situation. You can offer written backup. You can email an information leaflet. Then consider whether a follow-up consultation is needed and explain to the patient how and when that will happen. So make appropriate arrangements for this to happen and document. And then finally, documentation. So proper documentation in the patient notes is the cornerstone of any medical legal defence. So the documentation should reflect the mode of consultation too. So document whether you've done a remote consultation or whether a physical appointment was offered and taken up.
I think also for trainees who are sitting the RCA at the moment, where part of the assessment is looking at your communication skills. So having nuggets of advice about communicating effectively when you are consulting remotely is really helpful. Thank you for sharing that. So in your view, when patients have made a complaint, what are they actually expecting from us as doctors? Should we be responding to practice complaints to avoid escalation? Is there a time frame to respond? And would you advise a telephone call versus a formal letter? What actually works best and what is the most effective means to respond?
So a crucial part of a doctor's job is working effectively with patients after they experience some disappointment about their medical care and feel that they need to make a complaint. So having a formal complaints procedure in the practice will help to effectively manage and respond to a complaint. An apology is what most patients usually want the most, together with an acknowledgement of their distress. Most patients want the doctor to realise what has gone wrong and an explanation of why the incident had occurred. It's the lack of a timely apology that pushes people to complain and make a written complaint or even take legal action. And we know that dealing with complaints can be a difficult and time-consuming affair, and apologies are a valuable tool to use when handling complaints. An apology can take the heat out of the situation and help to prevent a complaint from escalating further. And remember, an apology is not an admission of liability. So from the practice point of view, the practice should identify who is the responsible person for managing complaints. For example, this may be a senior GP partner, but more often it's the practice manager. All complaints must be acknowledged within 3 working days of receipt. So that's in England and Scotland, and in 2 days in Wales and Northern Ireland. And a letter should be sent to the complainant setting out how the complaint will be investigated and informing them of the expected timescales. However, if it's an oral complaint that's satisfactorily resolved no later than the next working day, then they are not subject to the NHS complaints regulations. So once the investigation has been investigated and concluded, a letter must be sent to the complainant setting out how the complaint has been investigated. So you should also include the evidence that you've considered and the conclusion reached. And this letter should also include details of any actions that you've taken as a result of the findings. So, and this is an important point really, so sharing any learnings or changes that has been made as a result of the complaint.
I think that's a really important point, isn't it? Taking the positives from it, because it can often be very disheartening and certainly lower morale as well whenever we receive complaints. It's not a nice process to have to go through by any means, but actually looking at the learning points and see what we learn from them is such a valuable tool, and having that discussion and time for reflection with colleagues as a team works really well.
Yeah, and absolutely, and sharing the learning within the practice as well with all of your colleagues and the rest of the team.
Absolutely. Obviously, with overwhelming demands, increasing work pressures that we are hearing so much about and will no doubt continue to, many doctors we know are reaching burnout at the moment. Many have reached burnout, and sadly a lot have also left practice as a result of it. In your role as clinical risk educator with MPS, who you've been working with for many years, how does the Medical Protection Society support, look after healthcare professionals who are struggling with the demands of dealing with complaints?
First of all, helping our members to deal with complaints is one of the services that Medical Protection offers. So members can request assistance from us, and we have a dedicated complaints team who can support them in managing the complaint from the start to finish. So beside of that, we also have a number of resources available to our members to support them. And certainly over the past 12 months of the pandemic, we've produced lots of webinars and articles on managing complaints and dealing with burnout and well-being. And our members also have access to an independent, confidential counselling service as a benefit of membership.
And that's accessible at any time?
Yes, absolutely, 24/7.
Brilliant. That's really helpful to know. Thank you. And obviously more information is available on the MPS website as well.
Absolutely. Just go and have a look on the website. All the details are there.
Brilliant. Thank you, Dan. Are there any certain factors that make doctors more likely to get complaints?
Yes, and it's a fact of modern clinical practice that as a GP, you will all likely face complaints from patients at some point during your career. And there are a multitude of reasons why patients may complain. And one of the most important factors, again, is your ability to communicate effectively with your patients. So how you communicate and show empathy can be affected by your confidence, your peer support, workload and well-being, and also be impacted by career stage. But many doctors will experience a complaint, investigation, or even a clinical negligence claim during their career. And some of these could come from a patient, an employer, or via the General Medical Council, and could relate to any aspects of professional practice. Complaints against doctors have unfortunately become more common in the UK in recent years. And I think this is likely due to the increasing complexity of medicine and an emerging complaints culture amongst the general practice rather than any decrease in the doctor's performance. But MPS claims data and international research consistently demonstrate that patients' dissatisfaction with their doctor's communication fuels the majority of complaints. And poor communication and a perceived lack of caring is instrumental in patients' decisions to sue. And we know that studies have found that positive doctor communication behaviours increases patients' perceptions of the competence of that doctor and decreases their intention to complain or sue. So what might this mean for GPs? So I would say in addition to continuously perfecting your technical expertise, try to take time to also perfect your communication and empathy skills. And we have various resources to assist members in this area on our e-learning platform. But most patients note, if you think about it, they note the non-verbal skills of the doctor more than they report on other aspects. So, for example, you would rarely hear a patient saying, oh, that doctor's examination skills were excellent. You are far more likely to hear patients reporting, she was very kind, or he explained everything to me. So a doctor who is perceived by their patients as someone who listens, appears caring and kind, and is focused on their needs can go a significant way to reducing their individual medical legal risk.
No, again, I think that's really important. I think also having a really open and honest relationship with your patients is really important. I think being able to acknowledge and say, you don't have all the answers. A lot of patients who sometimes worry won't like that, but actually they are much more accepting to that. And then lastly, Dan, my question to you is, we obviously have, as healthcare professionals, doctors, annual appraisals. Trainees obviously have to continue to write their learning log entries. There is some skepticism, apprehension about how much information should be documented, should be added to our GP appraisals, our trainee portfolios. Can this ever be used as evidence against GPs at a later date? And is it something that a doctor should be wary of in your view?
It would be extremely rare for a doctor to provide the contents of their e-portfolio for anything other than educational purposes. And in any event, information that contained in there should be anonymised. So doctors must be open and feel that they can be honest when completing these reflections. So what's important is to record is not necessarily the details of the complaint, but more what issues it raises and what, if any, lessons can be learned and whether any change in future practice is needed. So reflective notes should focus on the learning, not a full discussion of the case or situation. So ensuring a learning culture is key to improving patient safety. And in fact, the GMC does not ask a doctor to provide their reflective notes in order to investigate a concern about them. However, they can choose to offer them as evidence of insight into the practice if they wish. And the GMC has published detailed guidance on reflection.
I think that's been really, really helpful, really insightful, and you've covered so much on the topic that is very important, very needed for us, especially at this time. Dan, once again, thank you so much for joining us today. As mentioned earlier on, if there's any further information that our listeners would like for MPS, you can go onto the website, and hopefully we look forward to having you back for more of our podcasts in the future.
Thank you.